Good evening, everybody. Such a privilege to be here once again with the case presentation from TriMed. I think many of you here are familiar with the way we work, the underlying concept. For those who don't know about us, I think a few minutes on the way we work, the underlying concept. So the essence of TriMed is a seamless integration of allopathic medication along with ancient alternative medical treatments such as Ayurveda, naturopathy, and along with the newer verticals such as the physiotherapy and the psychological treatments. So at TriMed, the patients are broadly divided into those with pain, disability, stress, and lifestyle problems. And here, I think what's most important is the multidisciplinary assessment, because we have a team which is led by the allopathic physician. We have 3 of them, headed by Dr. ESK, Dr. Srivatsa, and myself. And then we have the Ayurveda physicians, the naturopathy physicians, the physiotherapist, the psychological therapist, and the nutritionist. So today we'll take you through a case, and as we go through the case, I'm sure you'll understand the way we work, the way we approach a patient in a multidisciplinary manner, and how we go about customizing the treatment program and dispensing the treatments. So this is a 66-year-old housewife who was brought to us in February 2014 by her daughter-in-law and daughter. There's been a history of agitation and aggression for the past 1.5 years. She's been spitting and biting frequently. She's been wandering restlessly in the house. There have been memory difficulties regarding immediate events, names. She does not recognize family members frequently. She makes a lot of moaning sounds continuously. Speech is reduced. She has bladder incontinence. She is dependent for her activities of daily living, and her movements have become slow. She's not hypertensive or diabetic. Thyroid status is normal. The family noticed retrospectively that there was an insidious onset of memory loss from 2004, and they made the observation that she looked depressed after her daughter got married and went away. And they observed that she'd forgotten to wear a sari, which is the traditional Indian dress, and she'd forgotten how to cook. She was mixing up ingredients. She was forgetting to switch off the stove, which would have been dangerous. But however, she was allowed to manage the household chores up to 2007, with her husband pitching in a lot. And after this, the symptoms became very obvious. And the family said that there was a rapid deterioration in the past 1.5 years. And they said there was family history of similar symptomatology in an aunt who passed away after 2 years of a similar history when she was 83 years. Coming to general and neurological examination, she was extremely restless. She was very uncooperative for examination. She was making these noises continuously. The only thing we got out of her was her name. And as we go through the slides, you will see that she's always agitated when she's questioned continuously. There was a perseverance of speech. She kept saying the same things again and again, very few words though. And she used to walk around the room. We noticed that there was a decrease in the blink, and we elicited the glabellar reflex. We found that the tone was increased in all the limbs. All the deep tendon reflexes were retained. The plantars were bilateral extensor, possibly striatal. And there was no arm swing, both sides, when we saw her gait, and she was stooped forward, and her vital parameters were normal. As I said, we do this multidisciplinary assessment. So after I had seen the patient, we had our specialist physical therapy, Mr. Yuvraj, who did the assessment. He found that there was a lot of muscle spasm in the neck, in the back and the legs. The fine motor skills were poor. The balance was very poor while walking and standing. She needed help. People had to hold on to her while walking. And the range of movements were restricted all over the body with rigidity of all the limbs. The psychosocial assessment was done by a psychologist, Mrs. Yogini Nath. I don't think she's here with us today. She found that there were mood difficulties, aggression, behavioral difficulties, there were sleep disturbances. Premorbidly, she had been short-tempered and impatient. There was poor eye contact. She was dressed in her night clothes. There was abnormal vocalization and gestures. There was no engagement with the examiner. There were repetitive abnormal gestures, aggressive, like I said, when repeatedly asked questions, and she threatened to punch her, which didn't happen with the rest of us too. There was poverty of speech, global aphasia. MMSE could not be done. We could also not do any of the neuropsychological tests. So I don't know, we'll pass muster with such an audience, but I think you should give us our inputs as we go along. There was no time, place, or person orientation. There was poor concentration, global memory deficits, mood and affect, irritable and fearful. Mood was depressed. There was poverty of thought, and judgment and insight were impaired. Well, the positive investigations were a very low B12. The C-reactive protein was elevated. There was an elevated ESR. The MRI brain picked up only diffuse cerebral atrophy, and the MRA of the brain was normal. So working diagnosis was PD with Parkinson's disease with dementia. So we admitted her in hospital soon after. She was treated with parenteral antibiotics for the elevated C-reactive protein. And for a possible non-specific inflammation, we gave her small doses of methylprednisolone along with intramuscular vitamin B12. The ACHE, the acetylcholine esterase inhibitors were started, and she was also put on a comprehensive care program. Medication, the mood stabilizers, like I said, the ACHE inhibitors were there. There were medicines for the Parkinson's, and then there were supplements, the B12, the calcium, and the vitamin E supplements. So, like I said, the modus operandi is an integrated therapy program. So, along with the allopathic medication, we put in place a customized integrated therapy program based on the multidisciplinary assessment. So this was a program which was led by Shubha. It was CRT led. There was cognitive retraining along with some other treatments. So I will talk to you about that later after Shubha comes in and explains what she did with this patient. Shubha is a senior consultant. She's a medical and psychiatric social worker. She's worked with people across the spectrum. She's very good with kids. She's also very good with the elderly and, of course, those in the middle. So, Shubha.
Thank you, Dr. Rama. Shakuntala Devi was referred to me for CRT. The first day when she walked into my room, Rama was just talking to you about being punched, and I asked her, "Ma'am, why don't you sit down?" She just looked at me and she said, "Who are you?" That was the first question, and why am I here? So her daughter-in-law tried explaining to her that you're going to undergo a treatment and she's going to help you to get better. So when we asked her to sit down, the next thing was that I got slapped lightly across my face because she said, I don't like the room, I don't like you, so can I leave? So the first 3 sessions that I had with her, I couldn't do much of progress because every time she walked in, she was extremely aggressive and she used to keep asking for her husband. She's the word for husband in Malayalam is acha, so she used to keep repeating acha, acha. And since I initially didn't understand what acha stood for, I kept asking her again and again, what do you need, what do you need? And repeatedly, it used to be a combination of both of us it was more like a Tom and Jerry game, each of us trying to find out what the other person was going to do next. I had a breakthrough when her daughter-in-law came in. There has been certain lapses in caregiving in her family because she has been actually taken care of in bits and pieces by her daughters, then her daughter-in-law pitches in. So there have been lapses. So we also found it difficult when we were working with her. So when her daughter-in-law came in is when I realized that acha meant husband. So we asked him to step in for the next session, and that was, I think, the 4th or the 5th session. When he came into the room, I saw a marked difference. A very docile, very compliant, very quiet person, quite a contrast to the lady I was working with in the last 3 or 4 sessions. And what was interesting was when he said, Shakuntala, pick up the pencil and write, she tried writing her name. Pick up the pencil and color the figures that you're being asked to do. She started doing it. So that was kind of a breakthrough session, after which I found that she had become a little more compliant, and she was willing to listen and she was responding. In between the 2 sessions or 3 sessions, we found that there was a visual, she had certain amount of visual hallucination, and that actually the family had a history behind it. Apparently, like Rama said, in 2004, 2005, she'd gone to a place in India called Varanasi, which is very famous for religious purposes, and during that time, she was asked to take a dip in the Ganges, and when she took a dip in the Ganges and came out, apparently she started shouting and screaming and moaning, and people didn't, her son and husband didn't know why she was doing it. Post that is when they saw a deterioration in her behavior. So this visual hallucination used to come in when we would talk about water, or would you like a glass of water? She would start off in Tamil, Tanni vendam, which means no water. Avan nikran, there's somebody standing. So that's still a question because we're not able to elicit what happened with her. So we are trying to work on that. April, we saw that she became more cooperative, eye contact improved. Increasingly, she knew my name, and I was the most hated figure for her because I was the one who would make her write, ask her a lot of questions, and I don't know how many of you understand Tamil in this audience. I used to be referred to as Koranga, which means monkey. Okay, nee vanditya, you're going to ask me questions. That used to be her common refrain. But what I found was that she started enjoying the sessions. She would come in and ask me, color pencil ilya? Where are the color pencils, and where is my paper? And she enjoyed playing on the tab. So Tap the Frog, and the next slide would say that we were doing all that with her. Tap the Frog was her favorite game, is still her favorite game. She enjoys playing Tap the Frog. Squashing the ant. She would react like a small child every time she got an ant squashed, and every time she did that, she would have a bonus. We would give her a star and she would get very excited. So slowly I saw a change, and her aggression levels were also coming down. And she apparently pre-morbidly was an extremely devotional person who enjoyed listening to devotional songs, and that was an input again given to us by her daughter-in-law. So I started playing certain, background music, certain ragas which tend to calm the person down. And she started enjoying the music. In fact, the minute she would walk in, she identified the song more than anything else, and she would say, why aren't you playing that song? Why aren't you playing this song? And when certain things which we noted during the therapeutic process was there was a timeline when she was still connected to the past. When I would ask her to identify political figures, it would often be MGR. She still hasn't come beyond MGR. So anybody, but she could associate our present chief minister. Very surprisingly, she said, she acted with him in all these movies. So I know who she is, but she couldn't get her name, but she knew who it was. So that's when we started association and reminiscence therapy with her. In reminiscence therapy, interestingly, when she would look at the old albums, her children, she would come out with incidents about her son being extremely mischievous and how he hung upside down from the terrace and how she was scared he would fall down. And this photograph was taken immediately after that because I was scared he would hurt himself. But her husband suddenly passed away in the month of March, and reminiscence therapy actually helped us to help her handle her grief also. The minute she looked at the album with his photograph, she broke down and she kept asking, where is Acha, where is Acha? So as of now, I know she understands that he's not around, but I don't know whether she's registered that he's no more. That's something because we're still working with her, it's an ongoing process. So I seriously don't know if she's registered that he's no more. But she understands that he's not around her, because she immediately comes back and she tells me, Acha illa. So it means that he's not there. The changes we find now after about 18 odd sessions is she enjoys coming to the sessions. She's far more compliant. She enjoys playing over the tab. She enjoys coloring, joining the dots, the 6 differences, and her speech has improved, her comprehension has considerably improved. When you ask her questions, she's able to relate to it and then answer accordingly back. There was a time when she started the sessions when the speech was very irrelevant. You ask her, okay, Shakuntalama, what did you have for breakfast? She would just look at you and say, Onadane saapten. That is, I had you for breakfast. So from there on, now we see when you ask her, Shakuntalama, what did you have for breakfast? She's able to tell you, I had 2 idlis, but I don't remember whether I had sambar or chutney. Second thing which the caregivers tell us is that she started watching television. And what is interesting is in the soap operas, when something goes wrong with the heroine, she starts reacting to it. So she starts screaming at the villain and she starts shouting and says, why are you doing things like this? So that's a very interesting trend for us, because she was not watching television, she was not reading the newspaper. She started reading the newspaper now. And she enjoys watching these serials, and increasingly now my CRT is based on questions based on those serials. So I ask her what happened in this serial. She comes back and tells me the daughter-in-law was sent out of the house, or this person did this. But she's able to associate, and she's... One more thing which we found as a team when we were working with her was that she's very stable when her daughter-in-law is in town, because she's an excellent caregiver, and they're very systematic and structured with the therapy. But when she is not in town is when there are lapses in the therapy. She's not able to come. And in between, after her husband passed away, they were coming to therapy on and off. At that point in time also her behavior kind of worsened. So they had to come back in for regular therapy again. So those are my inputs. Thank you.
So like I said, I'd come back to the alternative treatments that were employed. And the focus was mainly on the physical domains, because she had Parkinsonian features. So there were spasms in the limbs, and there were problems with gait, and there was pain. So the Ayurveda therapy was decided by Dr. Deena Dayalan, who is our physician, Ayurveda physician. So the treatment she underwent is called the Abhyangam, which is a whole body massage with warm medicated oil. So she had 14 sessions of these. And the naturopathy therapies included acupuncture. There were 14 sessions. And there were mud therapy, where the wet mud is applied. It's a special kind of clay mud. It's applied in the abdomen and wiped off after 20 minutes. It helps cooling down the abdomen, and a lot of GI symptoms vanish after this treatment. So she underwent 7 sessions of these. And there was reflexology, 7 sessions, massage of the palms and soles for 20 minutes. So she underwent 7 sessions. And whenever she came, she used to have 2 or 3 sessions, because the attention was very poor and she was not very cooperative. So we couldn't push her to too many sessions. So for many of the elderly, they plan this way, where they come in 3 or 4 times a week and they undergo 2 or 3 sessions at a time when they come. And the physiotherapy, she underwent 14 sessions. She underwent electrotherapy. There were exercises. Like I said, the balance was very poor. So there was a lot of gait training, and there was posture correction, because she used to stoop towards the front. And during the therapies, she was once sitting with her caregivers, and we were all actually in the next room, and she fell forward and hurt herself. So the balance was not too great, and she had to be rushed to emergency for some suturing. So I'll just a snapshot of the timeline of events. So she was brought to us in February. In March, there were hallucinations reported and a lot of vomiting after evening dose of the Syndopa. So this was removed. And in April, like Shubha said, we noticed quite a bit of improvement. The BPS had reduced, and though she remained unhappy when she was questioned. And the setback was when the husband passed away. And that was when she began having visual hallucinations about somebody standing in front of her. So the quitpin was increased. There was a night dose. And like I said, the Syndopa was causing vomiting problems, so that was decreased. And between May and August, we put her on the step-down therapy. So when we finished the intensive course of therapy, we stepped the person down so that there are some takeaways of the therapy. We also monitor the clinical status of the patient. So they come in once a week for several therapies. So this was a review she had with Dr. ESK, where he noticed that there were improvements in movement, cognition, and behavior. She was able to indicate her needs regarding the ADLs, and sleep and appetite had become normal. And she was responding well to the therapies we had chosen for a step down: the mud, the acupuncture, the physio, and the cognitive retraining. This was a letter we received from her son. It was mailed to us. So this is rather self-congratulatory, but this is what keeps us going. It's the clinical improvements, the appreciation we get from the family, there's a lot of hand-holding from many of our patients, and especially from the chronically ill patients. It goes on for a while. They have one caregiver who stays with them. It's mostly the spouse or it's a child, and then we have the others visiting from abroad. The son is abroad. Like Shubha said, it was the caregiver is the daughter-in-law and the daughter. So the son, when he came and met us, this is what he had to say about the work. So it's not done. There's a lot of work for us to do, and we will be monitoring the clinical status. We're hoping she will settle down. And there are also blood tests done to review the parameters to see that she's doing well. So any inputs, we'd be glad to have your inputs about what else we could have done. Like I said, I think there's not been much of formal assessment in terms of neuropsychological testing. So we don't have scores, so it's rather subjective. We'd like to have your inputs regarding what else we can do for this patient. Thank you.